what would make you diagnose glaucoma in a child? This will be clarified to us by Dr. Viney. Viney, please.
And yeah, so I think making a diagnosis in a child has been very clearly sorted out by the International Classification for Childhood Glaucoma, which says that any intraocular pressure greater than 21 millimeters of mercury, possibly on 2 separate occasions, with an axial length that is progressively myopic for that particular age, or corneal diameters which are greater than 11 millimeters in the presence of harp striae at birth, or greater than 12 at less than 1 year, or greater than 13 millimeters at any age, or there could be a progressive increase in the CDR or greater than 0.2 CDR difference between the two eyes, or there could be the presence of a classic glaucomatous optic neuropathy in the presence of focal thinning of the rim. And of course, if the child is old enough, you can get a visual field done to look for visual field effects. So if any of these two are present, then classically it is a case of a childhood glaucoma. So this particular diagnosis is sort of well respected by the pediatric glaucoma specialists all over the world. But if you are suspecting a child with glaucoma, then any of one of these need to be present. That means an intraocular pressure greater than 21 millimeters of mercury, an axial length which is increased for that particular age in the setting of a normal intraocular pressure, or a cornea which is showing an increased corneal diameter in the presence of a normal intraocular pressure, or a disc which is suspicious. Of course, visual fields are generally not done for children if the child is less than 8 years of age. So since pediatric glaucoma comes in a lot of forms, and it is sometimes difficult to say what is glaucoma and what is not glaucoma, for which you need an examination under anesthesia, in which case you have to be very clear that you have to tell the parents exactly what you are looking for, what has to be, what you're going to do ultimately with the child during this examination. You have to take a proper consent. It could just be an NLD block that you are dealing with. So that again has to be explained to the parents, that everything will be looked for in your child during this examination. And everything should be available in the OT. So basically, it has to be done in specialized centers which are dealing with pediatric glaucomas, where everything is available in the OT, including a tonometer and sometimes an ultrasound biomicroscope and an ultrasound of the posterior segment. So the sequence of examination and anesthesia before you diagnose it is the one that we follow in our center, is that we do an anterior segment examination, we measure the corneal diameter, and it is after that that we measure the intraocular pressure. That is when the effect of anesthesia is more or less stabilized. After this, we do things like refraction, fundus evaluation, and an axial length measurement. So this is what we follow at RP Center. What does anesthesia do to intraocular pressure? It does reduce the intraocular pressure by 3 to 4 millimeters of mercury, and that has to be understood when you are measuring the intraocular pressure, especially under the anesthetist that we use, which is sevoflurane or isoflurane in most of the centers. Then there are normograms by which you can compare the axial length of that child's eye with that of a normal, and this has to be well understood, because you see, if in a newborn the axial length is 19 or 19.5, then it raises a suspicion that there's something going on there. So therefore, at every instance, you have to have a suspicion in your head regarding what you are dealing with. But after all of this is said and done, you must also understand that there are effects of anesthesia, because sometimes if the child is glaucomatous and has to undergo anesthesia, there are multiple anesthesia that the child may have to go through. And there are some studies which have said that it causes some neurocognitive effects of anesthesia on the long-term development of the child. So if you have a child like this, where the corneal diameters are large and you have harp striae, it's almost sine qua non of a glaucoma. So I mean, it is more or less glaucoma. It's very rare that, these days you have forceps delivery and trauma at birth. It's more or less always that if the large corneas and there is a harp striae, you can think that there is a glaucoma. But if you see disc like this in a child, where you can see an asymmetry, but is this glaucoma? Obviously not, because the disc is large, and so therefore the cup is also large. So you have to take the whole picture into account before you actually consider what is glaucoma. However, on this particular case, you can see that obviously there is a glaucomatous optic neuropathy, and therefore this diagnosis can only be made by the clinician. It is glaucoma. What about these discs? These are all discs of myopic children. And if there is a child who has myopia, it is very difficult sometimes to distinguish whether it's glaucomatous or not. In fact, now they're saying that if it is a childhood myopia, and the myopia is increasing, there is a possibility that the child might actually have an underlying raised intraocular pressure, which is manifesting as a myopic increase in the axial length. Not only does the intraocular pressure rise cause a myopic change in a child, but even the myopic change in a child can cause changes in the fundus. And this is what we have also observed, and there are some reports from South Korea which show that there are changes in the morphology of the disc as the myopia in the child progresses. So for all evaluations of the disc, it's important that you photograph it, and in an OT setting, we have handheld cameras where you can actually take photographs. You can give these photographs to the parents, because this is something that you need to evaluate over a long period of time. So therefore, if the parents can show you that this is what my child's optic disc look like, then 2 or 3 years down the line, you can say, but yes, it is progressing or worsening or whatever, getting better. But if you can't do disc evaluation because of a corneal opacity, then sometimes you may have to use an ultrasound to actually look for cupping in certain cases. This was an interesting case. This child came to us with borderline corneal diameters, a disc which looked almost cupped, which was quite an extensive cupping, but the intraocular pressure was absolutely normal. So when we went into the history, we realized that this child was born premature, and he had signs of leukoencephalopathy. So sometimes you can have a disc which looks like being glaucoma, but actually is not, and therefore you need to investigate further to actually see whether the child needs treatment or not. So to summarize, I can only say that if there are HARP striae in the presence of large corneal diameters, they could probably be diagnostic. Intraocular pressure, because of the anesthesia, cannot always be relied upon, and especially sometimes the intraocular pressure will be absolutely normal and the axial length is going on increasing. So then you have to look at the disc also very, 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 very well, because there could be an asymmetry or a change in the progressive change in the optic disc, which could lead to a glaucomatous optic neuropathy, which can only be looked at when you do serial photographs of the discs. And of course, as I said, changes in the axial length could also be sometimes the only way by which you can diagnose glaucoma in a child. This was a recent child that came to me with normal looking anterior segment more or less, and very high intraocular pressures in both the eyes. He had high myopia, there was no family history, but the corneal diameters were somewhat small. We did a genetic testing. He was supposed to be diagnosed as juvenile open-angle glaucoma, but because it was a little interesting to me because the corneal diameters were slightly small, I looked for that, and we found a mutation in the COL4A1 gene, which incidentally the father also had it. Now when we examined carefully the child, this mutation is associated with a posterior embryotoxin and cerebral lesions, and when we examined the child carefully, we found that there was a posterior embryotoxin in this child. So the COL4A1 gene is associated with axon field rigor malformation and retinal tortuosity, but there was no retinal tortuosity in him. And these children require repeated MRIs primarily because they have cerebral vascular malformations. And when we did his MRI, we did find that there were some changes in the cerebellum. The mother also gave some history that there was swelling on one side of his face when he was born, but obviously they attributed that to the birth trauma, probably because of the forceps delivery. But it was interesting that because of a genetic diagnosis, we were able to screen the father, and the father turned out to be having high intraocular pressures, and he also had a posterior embryotoxin. So here it is not just the diagnosis of the child that is important, and it is not that it's glaucoma that you're always looking for. It's something much more than that. You see, a genetic diagnosis actually revealed so much in the family that probably we wouldn't have been, I mean, the child was operated and went on, and many years before a genetic diagnosis became evident to us, we were just following this child as a juvenile open-angle glaucoma. So sometimes we are not looking only for glaucoma, we are looking at many other systemic features, and these have to be ascertained, and that can only be done when you're really following up these children well. Thank you. And of course, I need to invite you all for our IPGS meeting, which is happening in the this December in 12th, 13th. Thanks.
Thank you, Vinay, for the